Hi everybody, it's Patricia Coughlin here, continuing in this series on common pitfalls in the practice of ISTDP. Now, ISTDP is what I practice, it's what I teach and supervise and write about, but many of the comments I'm going to be making are applicable to any and all therapists, almost regardless of your orientation. So I'll differentiate those that are very specific to ISTDP versus those difficulties that really any therapist can fall into. And the one I'm going to talk to you about today is something that happens right from the start, and it's the mistake of making assumptions about patients instead of actually assessing them. I see all too many therapists beginning to intervene almost as soon as the patient sits down, before they've done anything approaching an adequate inquiry into the nature, history, and severity of the presenting problems, which is both going to give you a greater sense of the kinds of conflicts responsible for those difficulties, but also, as you're gathering this information and feeding it back to the patient, you're getting agreement. So is this the nature of the problem? And this is when it started. And this is the theme about each time it recurs. So that's suggesting, right, since these symptoms seem to arise following loss, right, that there's some sort of unresolved mourning going on. Would you agree with that? So as you're doing your assessment, you're getting agreement about the problems, the goals, and then the task. So if you just jump in and begin to intervene without having gotten this adequate assessment, without doing a sufficient inquiry, and also without getting that agreement from the patient, you can very easily go wrong. And because you haven't done that foundational work, the patient can either just feel misunderstood and drop out, right? Or you can end up getting into sort of a battle with the patient and you disagree. In fact, research suggests that all too often therapist and patient have disagreements about the most basic things, like what the problems are that they're there to resolve. And so, since again, many of our patients enter with defenses in operation, like externalization, if the patient comes in saying that their husband or their daughter is the problem, and you engage in that by asking about all their difficulties and what the patient makes of it, instead of asking what the problem is that they are having in dealing with this person or their feelings toward the person. So if you don't deal with the defenses, again, straight away, so shortchanging both inquiry and the crucial phase of defense work, you can get into all kinds of trouble. And so I really want to urge you not to jump the gun, to take your time, to do a decent inquiry, to get that agreement, and then to begin to do the defense work so that you can acquaint the patient with their defenses and they can begin to see that their symptoms and presenting difficulties are the inevitable result of excessive reliance on these defensive and avoidant strategies. Again, in this way, you're getting agreement, you and the patient are on the same page, and you're much more likely to get off to a good start. So again, I see things going wrong right from the beginning in many cases where people shortchange these first phases and jump right into intervening based on their assumptions about what's causing the difficulty. So I hope this is helpful to you, and we will continue next week with more on the pitfalls that I commonly see in my teaching and supervision of other therapists. Thanks. Bye-bye.